Hello, everybody, and welcome to the GLODERM Training Committee Alopecia Awareness Series. My name is Linda Atten, and I'll be your host today together with Karen. GLODERM Training Committee is a training arm of GLODERM, and that is the International Alliance for Global Health Dermatology. The International Alliance for Global Health Dermatology is an official program of the International Foundation for Dermatology under the International League of Dermatological Societies, ILDS. The mission of the GLODERM Training Committee is to promote knowledge equity by improving access to education for dermatology trainees worldwide. We also aim to provide free educational events and opportunities to build networks and collaborate. September is Alopecia Awareness Month. This month is dedicated to raising awareness for alopecia and all related hair disorders, aiming to increase medical understanding and also the patient impact. This matters because it helps to promote earlier diagnosis, access to patient-centered care, and also supports advocacy for improved treatment options. It supports ongoing education and also evolving therapies and multidisciplinary management. How can you get involved in alopecia awareness? You can participate in our educational webinars and discussions. You can also share your clinical insights and resources with colleagues and also patients. You can engage with patient advocacy groups and research initiatives. You can also promote awareness via your clinics and also social media platforms and any other media platform you're aware of. So for this alopecia awareness series, we have a series of topics which we'll be discussing today. We'll discuss the basics of alopecia diagnosis and clinical cases, treatment trends, and research. We'll also do a live Q&A session. But for each session, of course, we have very notable speakers that will be talking to us and sharing their clinical experiences with us. For the remainder of this webinar, your audios will be muted, your cameras will also be turned off. If you have any questions or comments, please submit it via the YouTube chat function. Our speakers will also answer your questions during our live speaker panel later. I'll also be sharing information about GLODERM Training Committee and how to get involved in the YouTube chat box. Going into the treatment trends and research is Dr. Ronda Farah from the USA. We have Dr. Ronda Farah who will be joining us today. Dr. Ronda is an associate professor of dermatology at the Department of Dermatology, University of Minnesota, USA. Thank you very much, Dr. Ronda, for honoring our invitation and coming to speak to us today on this very important topic.
Hello, I'm Dr. Farah. I'm a board-certified dermatologist at the University of Minnesota in the United States. I'm an associate professor. I also just started a new dermatology clinic called Illuma Dermatology in Minneapolis, and I am a hair researcher, and I think I'm a hair expert. Let's talk about the treatment of alopecia. I have some disclosures. I've served as a consultant for Luminous. I'm an investigator for an upcoming Veridermic study. I've also been a consultant or participated in advisory boards or clinical research studies with the remaining companies. So my outline, I've only given a short amount of time, so I'm going to focus on two common hair diseases that dermatologists see, and I'm going to focus on the new treatments and the new drugs. We're going to kind of skip some of the easy stuff that many of us are already doing. So let's start with androgenetic alopecia. I think that nobody can deny that oral minoxidil for sure is the new kid on the block. While it's not FDA approved, originally it really started to trend just after COVID. Here we have the study from Sergio Vano-Galvin, and this was probably the study that really set this drug up in the United States. It was a retrospective, multi-center study of the safety of low-dose oral minoxidil in almost 1,500 patients. When I'm looking at starting minoxidil in these patients, low dose means less than 5 milligrams per day for me. I have a safety checklist. I want to know if they have any of these problems. It doesn't necessarily mean I won't give it. It just means there's probably a lower likelihood I'll give it, or I need to do more work to get approval from a cardiologist or a primary care doctor. Pericarditis specifically, heart issues, if they can't metabolize the drug correctly, they have they're on dialysis. Older patients, I worry a little bit about them, although there's a recent study that even older patients over than 65 do okay. And I'm always thinking about if they have lupus, if I could get some other cardiac issue. And then, of course, porphyria, pheo, and cryoglobulinemia, those are diseases where we do not give this drug. In that that study I showed you, there were these systematic events in that retrospective study. Out of these patients, 15% developed hypertrichosis, but most of them did not stop the drug because of that. Some had lightheadedness, fluid retention, and then some other symptoms here. I'm not going to read those to you, but only 1.7% discontinued. It's interesting, in the United States, the drug originally received a black box warning for the effusion that we talked about, that it can cause angina or that heart discomfort, and that it shouldn't actually be used originally in the US unless they've been on other hypertensive medications. They said it needed to be administered under close supervision. It's usually used as a with a diuretic to prevent fluid accumulation, and that was probably in those higher doses way back then. And then patients with malignant hypertension or those receiving guanethidine should be hospitalized when it's first administered. So I think a lot of the use of minoxidil has changed from when this box warning came out, but we should all be aware of this boxed warning. When I first see them, I get their blood pressure. If I think they're high risk in a cardiac or they're older, I might get an EKG. Um, if I'm going to dose the drug, I usually dose it at less than 5 milligrams. If the patient is larger or taller, especially if they're men, I might go over five. I will look to see if they've had a recent comprehensive metabolic panel to make sure nothing is really off. And I'll engage the primary care physician if they're very complicated. And then originally I was like, you should monitor your blood pressure weekly, but now I just check it in the office and I tell them if they are lightheaded, that first half day they take it, that they can check their blood pressure for me and let me know if there's an issue. Otherwise, we check it at their follow-up a few times per year, and it really, I've not had a single patient in the several, probably hundreds of prescriptions that have had a problem with their blood pressure. And in this study from the JAD, when they looked at the blood pressure at 2 to 4 hours, that was where there was an issue. They followed the blood pressure in 10 men, younger men. There was no statistically significant difference, but that highest reduction in minoxidil blood pressure was between 2 and 4 hours. Originally, people really wondered if the 0.0625 dosing would cut it for everybody. Would that be enough? So we have this publication showing that 0.25 didn't work, although it was one small publication. 0.25 in the United States is very difficult to get, but for those of you who have access, it didn't seem to pan out in this 2022 research letter. I'm willing to start 0.0625 for females. Um, but I now start at 1.5 for females with the new consensus guidelines. With patients who are anxious, though, I might start with this 0.0625 for females and 1.5 for males. But I've really moved now to 1.5 for females and 2.5 for males, or 1.25 for females and 2.5 for males. I think I said that correctly. Interestingly, in the last month, we have this new study comparing 2.5 milligrams versus 5 milligrams of male androgenetic alopecia, where they were blinded, the physicians were, and there was, no difference between the two groups in terms of hair growth in this double-blind randomized study. However, there were more side effects in the 5 milligram group. The patients on 5 milligrams, though, they felt like they grew more hair, but the physicians couldn't verify that with the data. So then we have these consensus guidelines that came out. So I just decided to pick out the things that, are kind of not necessarily intuitive in the consensus guidelines. So I'm pointing out a couple things here. One thing I found unique in that article is if you decide to discontinue it, the consensus guidelines recommend low dose oral minoxidil be used, that it be slowly discontinued if it's being used. And if a female is planning pregnancy, they should discontinue it 3 months before conceiving. So that is something to think about. Let's move on to low-level light therapy, also known as photobiomodulation or androgenetic alopecia. There are multiple devices on the market. These may use LEDs, light-emitting diodes, or diode lasers. Photobiomodulation is just this low level light stimulating the hair. We really are not sure how. There is an article in the JAD from 2024. Actually, it was our CME article focusing on this. We don't really know how it works, but you can see here on the screen, maybe the red infrared light hits cytochrome C4 in this mitochondrial membrane, which then results in an increase in ATP and intracellular calcium and nitric oxide. That may then stimulate out here increased transcription of things that grow hair, ATP, NF-kappa beta, insulin-like growth factors, etc. I think it definitely works. I think the data is there that it definitely works. Here we have a great study way back from 2014 demonstrating efficacy. Dr. Hordinsky was on it. I know that she's a speaker in this session. Also from Dr. Hordinsky and I's lab, we have hair growth in darker Fitzpatrick skin types. Originally, the device was only approved for our lighter Fitzpatrick skin types, and we had excellent medical students and fellows who had a great question. Would this work in darker skin types? And here you see, we did see improvement in our small little study, and that is to be published. In androgenetic alopecia, platelet-rich plasma. I think 10 years ago, I was presenting, I'm not so sure about platelet-rich plasma, but I think platelet-rich plasma is a great option that's not oral medication, like dependent on oral meds. And a lot of patients like that. The drawback, again, is the cost. PRP is typically 3 to 5 times whole blood. The FDA was defining it as at least 250,000 platelets per microliter. It's used off-label. That means in the US, it's not approved to grow hair. And there isn't really a standardized protocol to preparing it, but this is PRP prepared at the university. Many believe that PRP works because if you get a lot of the platelets, you get a lot of growth factors, and then you're injecting those growth factors, and then you grow more hair. But we're not really sure if having more platelets means more growth factors and more hair. And so many people think if you concentrate more, you get a better result. But the truth is, we don't really know, and maybe you could have too much of a good thing. So what you do is you collect the whole blood, maybe between 20 and 35 cc's of blood. You centrifuge it, then you aspirate the platelet poor plasma, the amount of plasma that has like very little platelets off the top, and then resuspend it. And some people activate it. We don't activate because we believe when we contact the scalp with the injection, we're activating the platelets. This figure is from Dr. Hordinsky and Javed Sheikh, our PhD in the lab. And, there's some evidence that TGF beta is inhibitory, but other growth factors could be helpful. So this is an idea and something we published in a book chapter, but more to come on how that works. Before the patient gets PRP, we have them get a baseline CBC to make sure they're healthy. They don't have like low platelets or a bleeding disorder, or they're not anemic. We make sure the scalp is clean. We have them take a shower or clean it the morning of or the night before. We make sure they're hydrated so that they don't get lightheaded and call with a headache. We do not discontinue anticoagulants or NSAIDs unless they're unnecessary or not prescribed by a physician. We adjust their expectations. This is going to take a minimum of 4 treatments, and that you could have an initial shedding. And then we do typically avoid if they're pregnant or they have a bleeding clotting disorder, although Dr. Hordinsky has a recent case where an OBGYN said it was okay to do in pregnancy, and the patient did okay. So I think with pregnancy, more to come, but maybe some collaboration with our OB colleagues to make that be okay. There are side effects. You could, of course, get bleeding. With PRP, when we're on the face doing filler, you could get an intraarterial injection. Ulceration can happen. Of course, it's very painful. You can use a Zimmer, which is a cooling device, or an air conditioner to help with pain. I like to use massage. You can also use lidocaine. There can be swelling. There can be bruising. You could get a hematoma. They can get headaches. So you do have to be really prepared for everything. I think after really going through the literature year after year, the trend is definitely upwards, and that PRP works for androgenetic alopecia. And here you see in the systematic review, 84% of studies with a positive effect, 50% of those with an objective measure, and 34% with hair density increase. This is my favorite article from Dr. Hausauer, who is an outstanding dermatologist. She's definitely an expert in regenerative medicine. So if you're looking to get an article that tells you, we typically inject monthly for 3 months, maybe one more time at month 4, then 3 months later or 6 months later as a booster. But if you're looking for more specific guidelines, you might take a look at this 2020 article. Let's move on to what's new in alopecia areata. So traditionally, of course, I do the usual topical steroids, it might be clobetasol or fluocinolone or fluocinolone. I'll do injectable steroids. I've really leaned towards using injectable 2.5 milligrams per cc. I'll typically, if I'm doing the whole top of the head, do 4 cc's of that. I try to avoid going over 40 milligrams of injectable steroid in one session. I think that that's really the top. And then sometimes I'll go above 2.5 to 5 milligrams or 10 if there's certain areas where it's very recalcitrant. Um, but let's talk about JAK inhibitors because we don't have much time and everyone wants to talk about the new emerging stuff. So what's going on in the US with JAK inhibitors? Well, they're increasingly, of course, being used in dermatology for multiple diseases. And they were originally FDA approved for rheumatoid arthritis. So a lot of the safety data, a lot of the labels, and a lot of our counseling are on a patient population that may have more medical issues at baseline. And this JAK family, which we're going to take a look at the mechanism, includes JAK 1, 2, 3, and TYK2. So when we look at the mechanism of action of these drugs, we need to understand the JAK-STAT pathway. The cytokine binds to the cell surface receptor, and then there's phosphorylation of the JAK tyrosine kinases. And then we have STAT transcription factors that bind. These form this hetero or homodimer. They go into the nucleus, and then we have gene expression. So, we have all these different pathways and all these different JAKs that can get inhibited. Tofacitinib was originally the promising drug. So tofacitinib inhibits primarily JAK1 and JAK3. And that is not one that is FDA approved. But here is where we see the evolution of the literature and that change. And this is one of our articles with Dr. Hordinsky demonstrating that tofacitinib is a good choice for alopecia areata. So if we can't get other drugs approved, we'll often use that publication. And then another study showing successful treatment of severe alopecia areata with oral or topical. Topical JAKs are hit or miss. It seems in the literature sometimes they work and sometimes they don't. So probably more work needs to be done to get the best formulation for these drugs. But if the oral JAK's not an option or the patient refuses it, I don't have a problem attempting to compound and try to treat as long as the patient understands it's off-label and it might not work and insurance might not cover it. In the US, 3 have reached FDA approval: baricitinib, ritlecitinib, and duruxolitinib. Baricitinib was our first, which really was miraculous as a medical student to see. I saw Dr. Hordinsky sort of trained me, her going from using minoxidil topically and injectable steroids and topical steroids to all of a sudden, the last 12 years since I've graduated, having these oral meds that we can give. It's amazing. It's like watching almost like cures. So oral baricitinib inhibits JAK1 and JAK2, FDA approved in 2022. Blocking the interfering gamma signaling pathway and preventing immune injury to the hair follicle. So the key publication for that was this publication in the New England Journal of Medicine for alopecia areata, and it was initially a once daily dose of 4 milligrams or 2 milligrams or placebo. For all of my JAKs, so it's too confusing for the team to remember each of the labels. So for safety, I just kind of get all of these things. So anything I would do for an immunosuppressed patient that I would want to screen. I'd want to get their quantiferon gold, looking for tuberculosis, their CBC, their CMP, their Hep B and C serologies, HIV, fasting lipids. Some of these require fasting lipids, like baricitinib, but some don't. But to keep it clean and easy for the office, everybody kind of gets the same. And then pregnancy testing. Of course, I don't want to start a patient who's pregnant on this or typically on some form of contraception when they start it. And if they're planning to get pregnant, I'll discuss it with the OB. And then with the third JAK inhibitor that's FDA approved, it is very important to understand those patients need to be tested, the Leqselvi patients, so the CYP2C9. For baricitinib, people start at 2 milligrams per day. If they're not improved, we go up to 4 milligrams per day. If they have near or complete scalp hair loss or, pretty significant eyelash or brow involvement, you could just start treating with 4 milligrams. And then if you get an adequate response, you can consider dropping down. And I think we know now that in many of these patients, if we stop the drug, that the hair loss will come back because this is a chronic disease. So it's not the sort of drug you want to tell people like, oh, you'll be on it for 8 months. No, like when you start it, if you want the results, you're probably going to need to be on it until something better comes along. So go through that boxed warning: malignancy, infection, thrombosis, major adverse cardiac events, vaccinations, at least shingles. I usually also try to have them get the pneumonia, the COVID, the flu vaccine. I make sure they're hepatitis vaccinated in the US. Any vaccine I can get into them. And then I'm looking at weight gain. I'm looking for, things like weight gain, headache, GI perforation, lab abnormalities, when you're kind of like talking to them about these issues, and then staying up to date again on their vaccines. Looking at JAK, specifically baricitinib, cold-like symptoms, headache, changes in their labs. Interestingly, these drugs generally, you get an elevated CK, but it's not something we monitor or follow. So it's possible to get some increased weight, and then just be aware of the pregnancy stuff we sort of talked about. And then for my safety checklist before I start people on these drugs, these are the things I want to know. Do they have diverticulitis, MI, stroke, any of these things that I've listed? I won't read it. Look at cardiac risk factors. If the patient already is diabetic, is not active, has high blood pressure, and smokes, that patient might be high risk with these medications. You want to look for patients that have that where the medication would be safe long term and the medication won't cause them additional problems. I'll do a total skin exam with baricitinib. I don't give it with probenecid. That's on the label, and I have used it with oral minoxidil, and it's been fine. Ritlecitinib is actually my favorite because I feel like the monitoring is not as intense. But regardless, I still kind of do the same for monitoring for all of them for patient safety to keep things easy and standardized. Anyways, so this one inhibits JAK3 and the tyrosine kinase expressed in the hepatocellular carcinoma. So oral ritlecitinib, most frequent adverse effects were upper respiratory, those cold-like symptoms, nasopharyngitis, and headache. There were 5 serious infections, 1 PE, 2 malignancy, and some zoster. That's why vaccination being super important. I've actually seen zoster from these drugs in the clinics, but no deaths or major cardiac events. There was an increase in CKs. And then for monitoring, again, I do all the CBC, all of these things to keep it standard, and the lipid panel in all of them so that things don't get missed and it doesn't get confusing. Because medical systems are confusing. And so for patient safety, I think it's easiest just to capture all those labs we talked about earlier on all of the drugs. Let's go into duruxolitinib. It's the third and final FDA-approved oral JAK inhibitor. Just got its approval. Greatest potency against JAK1 and JAK2, but also TYK2 and possibly some JAK3 when you look into that drug a little bit more. This one, you have to get that CYP2C9 genotype testing. I don't know how much it's going to cost. I don't know how hard that is really to get. I'm just starting to use it, and I literally just tried today to meet with the lab to try to order it. But that's something. And then this one, because the patient might not be a good metabolizer of the drug, you need to like make sure this test is normal, and then also check their drug list and compare their drug list to see if there's an interaction with duruxolitinib. And then if you look at UpToDate, if you have access to UpToDate or some sort of pharmacology checker, it'll take you through other CYP, metabolism pathways, and that this drug could have other issues with other CYP types. So this one, if the patient's on other drugs, could be a little more complicated and require lab testing, but it's nice to have this option. So here I think I listed the CYP2C9 inducer drugs that could decrease the serum concentration of it. If you have an inhibitor, it could increase the serum concentration of it. And then the CYP3A4 inducers, it might decrease the conservation or concentration of it. So just maybe working with a pharmacist if there's a long drug list on this one, or using one of the other ones if there's a long drug list that the patient's on and they don't pass that genetic testing. Finally, Dupixent's always out there. Although there are reports that Dupilumab causes alopecia areata, but there is this trial out there with 60 adults, 18% in the dupilumab group, 30% improvement versus placebo, but it did not reach statistical significance. But they said if the patients had a higher IgE or they had a history of atopy or there was a shorter period, like younger disease, that they did fine. So if the patient doesn't want to try and you're in a pickle and they have any of these features, it might be worth a trial. And then, of course, many of us start the JAK inhibitors with oral minoxidil. And here in 2025, just published, there's a retrospective study, and patients were on all their other therapies for alopecia areata, injectables and whatnot. And they were started on oral minoxidil. And in general, patients improved. And that was Brett King's publication. And then here we have oral minoxidil and oral JAKs combination studies. And I found Dr. Lisico, who's outstanding. She did the systematic review in 101 patients with 86 demonstrating a response with, again, a SALT score reduction, which was huge. So it seems like using these drugs together, or if you can't use a JAK inhibitor, then just using oral minoxidil might be helpful. Finally, let's talk about what's up and coming. So there is a new investigative agent that's coming out. It's a formulation of minoxidil that's in its final clinical trials. And actually, Aluma Dermatology will be participating and we'll be enrolling our patients beginning the first week of November. But VDPHL01, it's the first minoxidil extended release tablet. And we've been told that this formulation allows the drug to stay at a therapeutic level, and it's below what is believed to be the riskier level for cardiac issues. So by keeping the peak concentration below the FDA recognized cardiac safety threshold, they believe that it would reduce cardiac risk. So here they provided me this slide. Cardiac threshold, 20 nanograms per millimeter, ideal minoxidil plasma concentration, and then hair growth threshold. So that's the goal of this new investigational agent. I'm excited. I think it's going to be great for patients. It would be nice for dermatologists to have an FDA approved stamp on oral minoxidil. Other exciting new therapies is the new non-ablative laser. This new non-ablative laser is FDA cleared to ensure efficient, consistent treatments, and it only has one setting. You part the hair and you stamp it, and it's pretty efficient. It's a contact cooling tip, and it stimulates hair. It's a 1565 nanometer device, creates this laser coagulation, targeting to the hair follicle without destroying the hair follicle. The microbeams per centimeter squared is proprietary. From Dr. Sadik and from that clinical group, we have here a hair part that's now tightened after 5 treatments. Another new therapy is ultrasound, and then they use ultrasound to deliver a proprietary growth factor serum. I haven't used this one. I've heard it's exciting. It has a white paper on their website. I have not yet seen a PubMed publication, but I look forward to seeing it. It looks like it's also comfortable for patients, and patients feel like they see improvement. So, and then this is their white paper where participants were treated for 3 sessions. They had an increase in hair count, but I do think more robust studies are required. And then off-label, people are using the 1927 thulium non-ablative device with a product with growth factors, and they're calling it Carolase. And they think these microchannels widen the epidermis, hydrate the skin, might be helpful for hair growth. And then actually that works for the ultrasound one and for this one. So this is hydrodermabrasion, where we use water to cleanse the scalp. And so we take water and it's vortexed, okay? And you cleanse the scalp to improve scalp health. So here we have scale and seborrheic dermatitis, and it suctions back the fluid and improves scalp health. And you can deliver growth factors and salicylic acid and anything you want, essentially, through this to improve scalp health. Exosomes. I think there's just not enough data yet to inject patients with exosomes. I do not do it. I do not recommend anyone does it. I'm worried that the products don't have standardized regulation and they could be unsafe. And the FDA has reported contamination, even infections like hepatitis and whatnot, like issues with contaminated sources. There are topical exosomes available. I'm excited to see where all of these products go. I think the idea behind exosomes for hair growth is that you can derive them from the derma papilla or the outer root sheath, and then you can reapply them. And when you look at the literature, right? So you're looking at the literature for basic science literature, and I reviewed it. You'll see they're in mice and in vivo and in vitro in animals. You'll see in general all these things happen in these basic science studies: prolonged anagen, increased hair growth, and whatnot. But all of these different basic science publications, they're completely different. None of them are done the same. And so there's just so much research that needs to be done. So I would say exosome use, I would not use it at this time. And there's a recent article with the Carruthers, who helped with botulinum toxin on it, one of the Carruthers gene on it, and it was called Exosomes Exposed. So they have not made it to the level of evidence that I'd like to see if I'm going to use it on my patient and charge them for that. So my conclusion is androgenic alopecia, minoxidil and PRP are solid treatment options. Alopecia areata, JAK inhibitors, super exciting. These are game changers. Topical data, less clear. Or minoxidil in conjunction can be helpful, and many of us are using that. And then there's all these new technologies that are emerging that are exciting and probably generally pretty low risk. So I'm excited to see where that goes. So I want to thank everybody. If you'd like to find me, you can find me at Dr. Ronda Farah, no H in Ronda, on Instagram, Twitter, Facebook, TikTok. And I'd like to thank my research team. And Katie's picture's not on here, but Katie Plampton helped me finalize this lecture. Kim made a lot of the figures. Dr. Hordinsky, who trained me in hair loss. Gretchen, who runs all the clinical research now. All of these, Brianna Powansky did the figures, Sophie Frickty. So all of them are amazing. So thank you all so much, and thank you for listening to my talk.
Thank you very much. You can follow us on all our social media platforms to learn about upcoming events, webinars, programs, and more. And you can also get involved with us by being a member of GLODERM by scanning at the top right-hand corner. Thank you very much and have a lovely day.